In this video, we will discuss common inflammatory and infective disorders of the eyelid. It is classified broadly into allergic disorders, immune-mediated disorders, bacterial and viral conditions, with emphasis on clinical features and exam relevance. Acute allergic edema. It presents as sudden, bilateral, painless eyelid swelling. The edema is boggy in nature and often associated with conjunctival chemosis. Vision is usually unaffected. It is usually due to allergens or insect bites. Treatment is usually conservative. Cold compresses and oral antihistamines are sufficient in most cases. Steroids are rarely required. Contact dermatitis is a delayed hypersensitivity reaction commonly caused by topical medications or cosmetics. Patients present with erythema, edema, scaling, and intense itching of the eyelids. Management involves identification and avoidance of the allergen. Mild topical steroids and cold compresses provide symptomatic relief. Atopic dermatitis is a chronic condition commonly associated with other atopic diseases. Eyelid involvement presents with thickened skin, fissuring, and recurrent inflammation. Secondary infection is common. Treatment of the lid features is with emollients to hydrate the skin and the judicious use of mild topical steroids such as hydrocortisone 1%. Dermatomyositis is an immune-mediated disorder characterized by proximal muscle weakness and a characteristic heliotrope rash involving the eyelids. It may be associated with underlying malignancy. Management options include systemic steroids or immunosuppressives. An external hordeolum is an acute bacterial infection of the lash follicle or associated glands. It presents as a painful localized swelling pointing towards the skin. Most cases resolve with warm compresses. Topical antibiotics may be used, and incision and drainage is required only if abscess formation occurs. Impetigo is a superficial bacterial infection caused by Staphylococcus aureus or Streptococcus. It is characterized by golden yellow crest. It commonly affects children and is highly contagious. Treatment is with topical and sometimes oral antibiotics like beta-lactamase resistant antibiotics and preventive measures to reduce transmission as the condition is highly contagious. Erysipelas is an acute streptococcal infection involving the dermis presenting with sharply demarcated erythematous plaques and systemic symptoms. Treatment is with oral antibiotics, but recurrence is common. Necrotizing fasciitis is a life-threatening progressive soft tissue infection characterized by rapid tissue necrosis and severe systemic toxicity. It is a medical emergency and early surgical intervention is life-saving. Unless early aggressive treatment is instituted in the form of surgical debridement, and high-dose intravenous antibiotics, death may result. Molluscum contagiosum is caused by DNA pox viral infection. It presents as pearly, umbilicated lesions on the lid margin and is an important cause of chronic unilateral follicular conjunctivitis in children. Although many cases resolve spontaneously, removal of the lesion is recommended if conjunctivitis persists. Lesion excision, curettage, cryotherapy, or cautery are the treatment options. Herpes zoster ophthalmicus is caused by reactivation of varicella zoster virus. It has a unilateral dermatomal distribution. Severe pain precedes the rash, and involvement of the tip of the nose suggests ocular involvement. This sign is called Hutchinson's sign. Herpes simplex infection presents with grouped vesicles on an erythematous base and may occur as a primary infection or reactivation. It may involve eyelid skin and conjunctiva. Eczema herpeticum is a severe disseminated herpes simplex infection occurring in patients with atopic dermatitis and requires urgent systemic antiviral therapy. In many patients with herpes simplex infection, the inflammation will gradually settle without treatment over about a week. If treatment is necessary, a topical or oral antiviral agent can be used. Antibiotics may be required in patients with secondary bacterial infection. Recognizing key clinical cues helps in rapid diagnosis. Boggy painless edema suggests allergy. Honey-colored crest indicate impetigo. Umbilicated lesion with conjunctivitis suggests molluscum. Pain preceding rash suggests herpes zoster.